Ravikiran, your camera is upside down. Ravikiran, கேக்குதா?
Ravikiran sir, your camera is upside down.
Which one, Adarsh?
Ravikiran sir.
Should we put share screen, Adarsh?
So you are doing a lighting of the lamp?
Yes.
So you don't have to share the screen then, sir?
That's all, same thing. Whatever we are doing, that's all.
Yes, yes. So it's visible. So whatever you're going to do, it's live, sir.
Sure, okay.
But if you pin it, everybody can view it though.
Huh? If you?
Pin it.
No, that is something that IT industries used to do. They can do what is called a spotlight.
Yeah.
Whoever is speaking, can you put a spotlight on it, please?
Yeah, he's got it. Yeah.
Thanks.
Good evening, doctors. Warm welcome for the inauguration ceremony of Trendo 2020. Trendo 2020 is the 8th annual conference of the Endocrine Society of Tamil Nadu and Pondicherry. This year, Trendo 2020 will be held as an virtual face-to-face in the view of COVID-19 pandemic from December 4 to December 6, 2020. I welcome the patrons of ESTN, Professor A.K. Das, Senior Endocrinologist from Pondicherry, who is present here. Welcome, sir. Dr. S. Murthy and Dr. P.G. Sundaraman present virtually for this session. Welcome, sir. I welcome Dr. Krishna Seshabri, President of ESTN and the Organizing Chairman of Trendo 2020. Welcome, sir. I welcome the President-elect, Dr. Thomas Paul, for this session. I also welcome the Vice Presidents, Dr. Sriram Mahadevan and Dr. Suresh Damodaran for the conference. I invite Dr. Muthukumaran Jayapal, the Secretary of ESTN and the members of the organizing team for Trendo 2020. Once again, I welcome you one and all. Now I request Dr. A.K. Das, the Honorable Patron and our organizing team to light the Kuthuvelakku followed by the prayer song. Praise. Now I request Dr. Krishna Singh Shabri, the President of ESTN and the Organizing Chairman of Trendo 2020, to give us a few words on this session.
Good evening, everyone. We light a lamp. Tamasoma Jyotirgamaya. Take away from darkness to light. Very interestingly, one of the invocations for a lamp says, Shatru Buddhi Vinashaya Deepa Jyotir. What light does is, it changes the attitude of someone who's against. That is the power of knowledge. It is the power of knowledge and the sense of sharing and the need to network, to be together, learn from each other, to collaborate and grow together, that the Endocrine Society of Tamil Nadu is doing. I remember very well the discussion that we had in Bangalore, phone call to Dr. Kannan, the discussions with Dr. Murthy and Dr. Sundaraman, and then creating this particular. If you look at the backgrounds, you will find the very, very column-like icon of Endocrine Society of Tamil Nadu. Zoom in closely, you can see the organs there: the pituitary, the parathyroid, the adrenal, the pancreas, and the thyroid. But underneath that is the guiding principle of the Endocrine Society of Tamil Nadu. Tottanai Thurum Manarkeni Mandarku Kattanai Thurum Arivu. Meaning that the more we learn, the more we share, the more we impart knowledge to other people without reserve, without holding back, the more we grow. And that is what we have done from a very small organization. We are now a brand. We are somebody that India and this part of the world looks forward to amazing science and great conferences. Well, everyone talks about the bad parts of the lockdown. The good part of it is normally we will not be able to afford to bring together so many wonderful international speakers. And here we are having so many international speakers under the banner of Trendo this year. The team at Pondicherry, Puducherry, has taken the lead with Dr. Vijay Bhaskar Reddy, Dr. Satish Kamalanathan, Dr. Deenabandhu Naik, Dr. Jayaprakash Sahu. And I think our own Karthik from Chennai is almost a Pondicherrian in his heart. So they have put this together, and this would not have been possible without their work. And of course, the anchor, the person who says less, but pretty much controls all our lives is Muthukumaran Jayapal, and he is the glow behind the head. And with the help of our patrons, our youngsters, this society is growing from strength to strength. I will tomorrow, in my last talk to the society as its president, will try to outline some of our challenges and where we will go forward. But what is clear is one thing, that in this time of transition, in this time of pandemic, in this time of disinformation, in this time of pseudoscience, in this time of threats to our profession, it is almost important for us to stay together, to learn together, to grow together, and be together. I think ESTN and Trendo is a message of togetherness. And I hope that this remains the theme of this conference, of growing together and taking part in that infinite lake of wisdom that Tirukkural and our motto, Vaழிய செந்தமிழ் வாழ்க நற்றமிழர் வாழிய பாரத மணித்திருநாடு Vande Mataram. Thank you.
Thank you so much, sir, for your session. Thank you so much for your innumerable words, sir. Now I request Professor A.K. Das, the Honorable Patron and our organizing team, and our organizing team's guideline to deliver us a few words on this session.
My dear esteemed colleagues and friends, today is a great day, and I will not. We have only 15 minutes for the inauguration, so I'll be very conscious to tell that the Trendo, Professor Murthy is here, Krishna is here, Muthukumar is here, everybody, Velayudan is here. I must tell only one sentence. Trendo has set a new trend in before our country. It is the trend for others to follow. I'll just launch one thing from the Keshu's presidential address today when he said, only by what we do not become poorer but become richer and richer is by sharing the knowledge. And I'm extremely happy that this Trendo, 8 is a very important number, is numerically very, very important. On this 8th Trendo, we are going to celebrate with a host of national KOLs and ever bigger international speakers, researchers, and scientists and physicians of repute, the various areas of endocrinology, metabolism, and diabetes. Dear friends, needless to mention, endocrinology, metabolism, diabetes has become today the most important contemporary challenge. And the sessions centered around these topics, beautifully planned by our scientific committee chairman, with the aided by president and others, are bringing home the state-of-the-art clinical, practical things. And I'm sure this will be a great progress in the field of endocrinology. And if all of us can use this clinical practice, we will hope our endeavor successful. Dear friends, long live Trendo, and this 8th Trendo will set a new trend in front of the country. Thank you.
Thank you so much for your words, sir. I request our patron, Dr. S. Murthy from Chennai, senior endocrinologist, to deliver us a few words on this session.
Good evening, friends. It has been difficult times, a very challenging time, and it is indeed a privilege to congratulate the organizers under the guidance of Dr. Krishna Seshadri, Vijay Bhaskar Reddy, Sadish Kumar, Sri Ram Mahadevan, Muthukumaran, Kumaravel, Jai Prakash Sahu, Bharat Naik, Karthik, and the rest of them for having put up such an excellent scientific program. And we are going to have nothing less than an academic feast for the next few days. And I would also like to thank Dr. Krishna Seshadri, who will be laying down office tomorrow. He has been guiding the ESTN through very, very difficult times, challenging times, turbulent times. Of course, he will continue to mentor and take care of the ESTN. So, all participants, relax, sit back, enjoy, and have an academic session. Thank you.
Thank you so much, sir. Now I request our honorable patron, Dr. P.G. Sundaraman, to deliver a few words on this occasion. Now I request Dr. P.G. Sundaraman to deliver us a few words on this occasion.
Respected friends and colleagues and professor, at the outset, I wish to thank the organizers of this Trendo meeting for bringing up this wonderful scientific session ahead of us. Yadum Ure Yavarum Kelir. In the continuation of what Krishna has told, that whatever we have learned, we communicate and make the science to grow. So in the same sense, so whenever we acquire that knowledge, then we are able to communicate in a better way. And that's what is this Trendo meeting. Every year we are doing it, which is definitely going to very great heights with laurels. A lot of people are waiting to have this Trendo. In fact, when we didn't have this Trendo this year earlier, I was really shocked. And I think fortunately, now we are having by Zoom meeting. And this also paves the way in future that we can have a direct and Zoom combined together so that we can have a greater access of the doctors, not only in India, but all over the world, and which will highlight the torch of Trendo. I thank you once again for the organizers. Thank you.
Thank you so much for the wonderful words, sir. Now I request Dr. Vijay Bhaskar Reddy, the consultant endocrinologist and the organizing secretary, to deliver the vote of thanks.
Thank Endocrine Society of Tamil Nadu and Puducherry for giving the opportunity for conducting Trendo with Puducherry team. Due to COVID-19 situation, I think we are doing on a virtual platform for this time. We have tried to involve many international speakers, and we have tried to make the scientific content excellent. So we have sessions over the next 3 days. I thank the president of the society and all the dignitaries and the patrons for having joined us for the inauguration. We will move on to the scientific sessions, which start at 4 o'clock. We have sessions in Hall A and Hall B. I thank one and all for their support for conducting Trendo. Thank you.
Thank you so much, sir. Let's move on to the scientific sessions. The first scientific session will be on a thyroid symposium, TFTs, Hypothyroidism and Thyroxine Symposium. I welcome Dr. Velayudham from Royal Care Hospitals, Royal Care Super Speciality Hospitals, Coimbatore, Tamil Nadu, to take over this session. He has multiple publications. He is the organizing secretary of Trendo 2016. I welcome you, sir, to take over this session and to introduce the speakers.
Thank you, everyone, and very good evening. At the outset, my congratulations and best wishes to Dr. Vijay Bhaskar Reddy and the rest of the team from Puducherry for a successful Trendo 2020. And without wasting much time, this session over the next 30 minutes is on an interesting topic, which is rather a common clinical problem which we all see both at the primary care as well as the tertiary care. For that, we have Dr. Ravi Kiran, who is an endocrinologist from Chennai. He did his graduation super specialty from PGH Chandigarh, and he is currently practicing in Chennai at Diaplus Endocrine Clinic and SIMS Hospital. And he will be delivering a talk on a common clinical issue, that is the interpretation of thyroid function test. Thyroid function test, apart from blood sugars routinely done in our clinic, is a very common test, that is lab test that is ordered. But the interpretation of thyroid function test once done can be quite challenging sometimes. And we have Ravi Kiran, who is going to talk on that. Let's have Ravi Kiran, please.
So
the talk will be for 20 minutes, and at the end of the session, we'll have some discussion for around 5 to 10 minutes.
okay, sir. Okay.
Ravi, you can take over.
Yeah, okay. Yeah, just 1 second. Am I audible, sir? May I go ahead?
Yes, you are audible and your screen is seen.
Okay. Thank you for a kind introduction. So today it's going to be a basic topic. We will discuss it for 20 minutes. Then any questions, relevant questions, situations can be discussed. So we all know day to day we are all using all these thyroid function tests. We are all very familiar with them. TSH, total T3 and total T4, free T3 and free T4. Many types of thyroid antibodies, thyroglobulin, radioactive iodine uptake, and technetium thyroid scan. These are all commonly used tests in day-to-day practice. We'll be seeing in brief about each of them. The main thing to keep in consideration is the feedback nature of every endocrine mechanism in the body. If we focus on the first part of the slide, the leftmost slide, this is the commonest scenario we encounter, that of primary hypothyroidism, where the thyroid gland itself is at fault Thyroid gland secretes T3 and T4. The secreted T3 and T4 reaches pituitary through the circulation, and either it inhibits TSH or it stimulates TSH depending on the level of T3 and T4. Whenever it is low, the stimulatory effect, the inhibitory effect on pituitary is released, more TSH is secreted. The extra TSH is supposed to improve the thyroid gland function and make it secrete more T3 and T4. This is the homeostatic mechanism inside the body. Whenever it fails, the thyroid gland does not respond to extra TSH secreted from pituitary, overt hypothyroidism ensues. So this typical picture of primary hypothyroidism will have low T3 and T4 and elevated TSH in an effort to drive the thyroid gland more to produce extra hormones. So this is the commonest pattern we come across in practice. The next pattern is that of hyperthyroidism. Here, the gland itself may be secreting extra hormones more than what is required for the body. It exerts negative feedback effect on pituitary, suppresses TSH. So the pattern will be showing increased T4 and T3 and suppressed TSH. This is the second common pattern we see. The next two patterns are fairly rare. We need not discuss it now. We will discuss it in the relevant section. In hypopituitarism, the pituitary itself is at fault. There is less of trophic hormone secretion from pituitary, low TSH, and consequently T3 and T4 production from thyroid gland is also low. So all three hormones will be low in central hypothyroidism or in case of hypopituitarism. So when interpreting thyroid function tests, we have to be careful that mistakes may happen at several levels. It could be pre-laboratory. Without taking into account the clinical context, if we interpret just the report, then we may go wrong. We have to look at age, pregnancy changes, current thyroxine therapy, any confounding medications, and whether the patient is suffering from some other non-thyroid illness. All these things, the clinician has to take a history. There are many possibilities in lab also for reports to go wrong. Assay interference is a well-known, well-recognized phenomenon due to heterophile antibody, anti-animal IgGs, anti-adothyronine antibody. So many phenomena can happen in the laboratory also. Post-laboratory, of course, many times we may come across rare disorders, but we may miss it. For example, resistance to thyroid hormone, TSHomas, which are quite rare, 1 in million, like that. So the common reasons for ordering thyroid function tests can be summarized in the following slide. Generally, it is done as part of general checkup as a screening for any possible thyroid disorder, where mostly TSH is done in isolation. Or the patient could be a known case of hypothyroidism. During follow-up to fine-tune the medications, we check thyroid profile. Or he or she could be a case of hyperthyroidism. Again, for fine-tuning the anti-thyroid drugs, we may need thyroid profile. A brief outlay of daily thyroid dynamics. T4 is the predominant secretory form, and T3 is derived mostly from T4 and some of it directly from the gland. We can see here the free T4 is secreted. Free T4 is almost 1 in 100 proportion to the bound T4, whereas free T3 is roughly around 1 in 30th or 1 in 10th proportion to the bound T3. So the concentration of the proteins also many times play a part in the in how the T4 and free T4 turns out. Thyroid binding globulin is the predominant binding protein. Thyroid binding prealbumin, and albumin itself binds about 10% of circulating thyroid hormone. So for purposes of screening for thyroid disorder, if you don't see a goiter, if the person does not have any symptoms of hypo or hyperthyroidism, serum TSH is normal, no further testing regarding thyroid is necessary in 99% cases. Suppose if serum TSH is high, the commonest association we see is that of primary hypothyroidism. Free T4 has to be added to determine the degree of hypothyroidism. If serum TSH is low, mostly it will be a case of thyrotoxicosis, either due to hyperfunctioning of gland itself or due to leakage in the gland called thyroiditis. Very rarely it could be due to central causes. So in cases, clinical scenarios where there is a clinical suspicion of something happening in the pituitary, for example, a young woman with amenorrhea and unusual fatigue and possibly, so that lady will require evaluation for both TSH and free T4, because a low TSH in such cases, isolated low TSH in such cases, may give us a clue regarding the pituitary lesion. So there are several permutation combinations how the thyroid hormones, the individual hormone levels may pan out. The commonest association is what we saw in subclinical hypothyroidism, where TSH is in the range of 4.2 to 10. The TSH itself is raised partially, but with normal free T4. So it is a gland in failure, not yet failed totally, but probably beginning of failure, we can say like that. So subclinical hypothyroidism, TSH will be elevated between 4.2 to 10 with normal free T4. There are several other reasons for similar lab pattern. Recent treatment of hypothyroidism, or the patient is recovering from a non-thyroidal illness. During the recovery phase, there may be a brief uprise in TSH level. Many drugs can cause this pattern, and heterophile antibody may interfere and cause this pattern. The other side, raised TSH with high normal or high free T4 can be found in central hyperthyroidism or resistance to thyroid hormone. So again, the opposite side of it, the contrary pattern, low TSH with a normal free T4, we can find in subclinical hyperthyroidism, where TSH could be between 0.1 to 0.4, but that free T4 has not yet risen significantly. It can also be seen in T3 toxicosis, where T3 has risen in isolation without much rise in significant rise in free T4. The T3 will be causing the suppressed TSH. And low TSH with low or low normal free T4, either it could be due to non-thyroidal illness like a critical care patient, or could be due to pituitary disease. This pattern we have to especially watch out for. And many times we will find persons with normal TSH but with raised free T4, maybe due to intermittent T4 therapy or familial dysalbuminemic hyperthyroxanemia or central hyperthyroidism. So like this, several combinations are there. The one to recognize in clinical practice, which we frequently come across, is this total T4, free T4 discordance. We have to recognize that TBG level may get increased, leading to high total T4 and normal free T4 during pregnancy and with estrogen therapy for any other indication. And TBG level will be decreased, and low normal TT4 and normal free T4 may be found in nephrotic syndrome or liver disease. So the clinical context in which we interpret is very crucial. I'm skipping this slide. So the point of this slide is there are several situations where different types of drugs influence the thyroid function lab parameters in different way. These are all found in standard textbooks. This need not be memorized. The point of it is the clinician always has to interpret thyroid lab tests in the particular context, keeping the clinical context in mind. Otherwise, the exact issue may be missed. So many times we do TSH for screening. When is it inappropriate to test only TSH, where we have to do free T4 in addition? Wherever we have grounds to suspect central causes, pituitary lesions, to detect central hypothyroidism, we have to do free T4 in addition. First few weeks after thyroxine therapy, again, TSH only gives partial information. We have to check free T4 also. Acutely ill patients, again, we have to test both free T4 and TSH. So a brief word about non-thyroidal illness, so-called sick euthyroid syndrome. The patient is apparently having low normal free T4. Whenever a patient is sick due to cardiac illness or due to some surgery or prolonged sepsis, especially ICU situation, the body tries to conserve its resources for just survival, not for flourishing, just for survival, thriving. So the TSH, there is a partial central hypothyroidism in such cases. TSH frequently falls for a brief while, maybe for 2-3 weeks, and eventually it rises. So during this phase, if we check it in the first week, there may be a dip in the TSH, but if you check after 3 weeks, the TSH would have again come back to normal. So again, we have to interpret the thyroid function test in the context of critical illness. Amiodarone is a notorious drug to cause different types of thyroid dysfunction. It can cause both hypo and hyperthyroidism. Whenever patient is on amiodarone, we have to check the clinical function, look at presence of goiter, and maybe do a thyroid scan. It will tell us whether it is thyroiditis or hyperthyroidism, and interpret taking all these evidences together. So monitoring levothyroxine therapy in primary hypothyroidism, whenever we start thyroxine, TSH itself will be useful as a guiding light after 4 to 6 weeks. If we want to modify the therapy within 4 weeks, then free T4 is useful for the purpose. Whenever we are following up pituitary lesion with hypothyroidism and hypothalamic hypothyroidism, free T4 always has to be kept in upper normal range. TSH may not be useful in such cases for follow-up purpose. In cases of thyroid cancer, where suppressive dose of thyroxine is used, usually the TSH is attempted to be kept between 0.1 to 0.05 range to minimize growth of any possible residual tumor. One peculiar aspect has to be kept in mind while interpreting thyroid hormone. Biotin, which is frequently used for hair fall treatment, it causes falsely low value in immunometric assays and falsely high values in competitive binding assays. We can withhold biotin for 2-3 days prior to assessing thyroid function. So other thyroid related tests, thyroglobulin, thyroid peroxidase antibody, TPO antibody, and Tss receptor antibody. Routine measurement of thyroglobulin and thyroid peroxidase antibodies are not necessary. Anti-TPO antibodies may be useful to predict progression to permanent overt hypothyroidism in patients with subclinical hypothyroidism. Somebody having very high TPO, we can perhaps predict that he or she will eventually progress to permanent hypothyroidism. Tss receptor antibody is a very useful test whenever we encounter a case of hyperthyroidism. It is a marker of Graves' disease. However, if we have found a diffuse high uptake on a recent technetium radiodin scan, Tss receptor antibody may not be necessary. And it is also useful as a prognostic marker for those with Graves' disease. Those having high Tss receptor antibody TRAB level may require higher dose or prolonged treatment, or may require indefinite treatment with medicine. So other options have to be considered for those patients. The next useful test in practice is ultrasound thyroid. It tells us whether there is a diffuse enlargement, whether there are solid nodules, cystic lesions, and also helps to identify suspicious nodule for FNAC. For example, we can see the thyroid gland here. There is a nodule with possible microcalcification, some irregularity in the margin. Might be a case of papillary thyroid CA. FNAC is indicated in such a case. So ultrasound gives a indication of how suspicious the nodule is. It helps us in choosing the right nodule for FNAC, and it also helps us to identify lymph nodal involvement. The next useful test in practice is technetium thyroid scan. We routinely do in cases where there is the history is not very clear cut. Wherever the history of hyperthyrotoxicosis is hovering between 1 month to 2 months, where there is no thyroid orbitopathy, no goiter. Wherever there is confusion between Graves and thyroiditis, we can use this. That is the most popular use of technetium thyroid scan in practice. Nevertheless, different pictures can be seen in technetium thyroid scan. Here it is for that purpose only. If we look at 5 o'clock position, that is a typical pattern of thyroiditis. There is a poor uptake in technetium thyroid scan. On the contrary, if you look at 6 o'clock position, a autonomous nodule will show up with high uptake in only one side of the one part of the gland, and the opposite lobe will be, the uptake will be suppressed. So this is typical of autonomous nodule. In Graves' disease, if you look at 12 o'clock position, there will be diffusely high uptake uniformly across all parts of the gland. That is typical of Graves' disease. Radioiodine uptake may be too complex and to take up during the discussion. Just enough to say that here a oral dose of iodine 131 or iodine 123 is given. The neck radiation counts are checked with the gamma probe over the next 24 hours. If there is a consistently high uptake over the next 24 hours, it is considered as a case representing hyperthyroidism. Many times in high turnover states, there will be early rise at 6 hours, but thereafter there will be a dip at 24 hours. It differentiates this high turnover state from hyperthyroidism. So the normal radiation uptake is around 5 to 15%. If it is more than 25 or 30%, it is taken as indication of hyperthyroid state. So that again gives us some indication regarding the etiology. If it is increased at 24 hours, either it could be early Hashimoto's thyroiditis or much more commonly hyperthyroidism due to Graves. It is decreased in hypothyroidism wherever iodine overload is there, like previous 2-3 weeks some CT scan is done with contrast, there the uptake will be suppressed, and in cases of subacute thyroiditis. But because of availability of technetium thyroid scan, radioiodine uptake over 24 hours is less frequently used now. Thank you all for patient listening. Any particular queries can be taken up during the discussion.
Thank you, Ravi, for that precise timing of your talk. It's exactly 20 minutes. So we have around 10 minutes for discussion, and we have a couple of queries here. Dr. Chandra, he wants to know what is the ideal timing of the thyroid function test sampling, whether it should be done in the morning or in the evening, whether it should be fasting or non-fasting. Any comments on that?
The TSH level is it after 10 o'clock, 10 a.m. in the morning, it starts going down. The sensitivity is less for picking up cases of subclinical hypothyroidism, especially in pregnancy. In all other situations, the difference between a TSH of 3 and 5 may not matter, except in pregnancy where it is crucial to start. So for pregnant ladies, the timing of thyroid testing may be crucial much more than the fasting or postprandial status. That's what many studies indicate, one including from our Dr. Sriram. Wherever possible, it should be done fasting, or if there is a choice, has to be exercised between taking before 10 o'clock and allowing patient a small meal. Taking before 10 o'clock is more important than keeping the patient strictly fasting. So the time of testing is very crucial. That determines the TSH level much more than the prandial status. Wherever possible, both have to be adhered to. Fasting plus before 10 o'clock or before 9 o'clock will be ideal in pregnant ladies.
Yeah. So I see if the TSH is grossly abnormal, then this timing may not really matter. But as Dr. Ravikiran was saying, when the TSH is going to be really determining the course of treatment, then it may be crucial. The other question is, as far as the thyroxine level is concerned, which is better, total T4 or a free T4? Any specific indications for performing either tests?
So it depends on how the lab quality and how well they are churning out tests. Suppose we are very confident of, we have a support of very good lab backup, then free T4 confidently we can order, and free T4 also eliminates many minor errors that arise due to, many times due to some drug intake or several other conditions. Nevertheless, I think most labs do, they have a history of doing well with assay for total thyroid hormone. It is simpler. Less mistakes happen with in estimation of total T4 than in free T4. The free T4 estimation in labs is a bit complex. Not all labs may be having a high volume and may not have enough experience doing it correctly. The chance of error is more with free T4. So considering that aspect, probably better to go for total T4 on a general basis. The total T4 is very useful during pregnancy also. It is universally accepted during pregnancy also. The database for total T4 is much more than for free T4. So considering the possibility of less mistakes, lab errors with total T4, and much more experience with total T4, and simplicity of doing total T4 even in a small lab setup, total T4 probably is a better overall general test.
Okay, so there is another general question. Does exercise affect thyroid function test? Does it have any effect?
I am not aware of any such studies where exercise has affected thyroid profile significantly.
And this you were mentioning about Tss receptor antibodies. So where does it have a place in the evaluation of thyroid disease? Does it have any what do you call therapeutic value, or does it help in monitoring some disease or anything like that?
Suppose if some patient presents with thyrotoxic symptoms of short duration, less than 2 weeks, there is thyroid gland tenderness, there is some mild feverishness, some viral syndrome is there in the background. Typically, in such cases, the diagnosis is clear-cut. We go for a diagnosis of thyroiditis. And in the opposite, where the patient is having thyrotoxic symptoms for months together, like 4 months, 5 months, with a goiter, possibly some orbitopathy, again, there is no confusion in diagnosis. So the confusion between Graves and thyroiditis arises in thyrotoxic symptoms of intermediate duration, maybe 3 to 6 weeks or 3 to 8 weeks, where goiter may or may not be there, and patient may or may not be having mild thyroid tenderness. In such cases, TRAB may be useful to give a pointer towards the right etiology. Suppose if we do technetium thyroid scan, then TRAB may not be required in most cases. So that is general population thyrotoxicosis. TRAB is also useful in pregnancy, especially for prognosticating or kind of anticipating fetal or neonatal thyrotoxicosis. High TRAB level may give us a clue towards such conditions. So for general population, generally we use it in cases of thyrotoxicosis of intermediate duration, maybe from 3 to 6 weeks, without goiter, without orbitopathy.
Okay, thank you, Ravi. See, we have a couple of other questions, I think, which will be part of the next session, which is a panel discussion on thyroid hormone replacement therapy, I think, which will answer those queries for Dr. Kaveri, Kasiraman, and others. So with that, I thank Dr. Ravi Kiran for that lucid presentation, and we will move on to the next session, which is going to be a panel discussion on, again, a common clinical problem. We just looked at the evaluation of thyroid function in the form of assessing thyroid function tests and interpreting them by Dr. Ravi Kiran. And during the course of discussion, he also highlighted other aspects of thyroid function as well, including the antibody titers and the nuclear scans for thyroid function. So in the panel discussion, we will be discussing more on the clinical aspect of therapy of hypothyroidism, which includes a panel of eminent endocrinologists from our state. For that, I welcome Dr. P.G. Sundararaman, sir, who is a senior endocrinologist from Chennai in Apollo Hospital, and he did his DM endocrinology from All India Institute of Medical Sciences. And we don't need a specific introduction of sir. He's a very eminent teacher, and he's been conferred with the Best Doctor Award for the year 2012 by the MGR Medical University. Welcome, sir.
Thank you.
And the next panelist will be Dr. Vignesh, who again did his DM from the SGP GI Lucknow. And he's practicing endocrinologist in Trichy at his own center. And again, he has a lot of publications in index journals to his credit. And the next panelist would be Dr. Anjali Satya, who did her graduation from CMC Vellore. And again, she's from Chennai, who is practicing in Vijaya Hospital and Apollo Specialty Hospitals. And again, she has extensive and vast clinical practice experience for more than 15 years. And we also have the next speaker for the session, Dr. Petros. Maybe you can also have some discussion with him as well during the course of the talk. So what I would do is I will just project a few clinical case scenarios, and I would invite each of the panelists to give their opinion regarding various aspects of the clinical thing which we are going to discuss. Can I share my screen? Am I visible? So I'm not going to make it full screen because I need to go on screen and off screen once in a while. So to begin with, we know that hypothyroidism is a very common clinical problem. It affects up to 5% of people worldwide, and it can present across lifespan from neonatal age to old age. And the gold standard for treating hypothyroid state is with thyroxine to achieve and maintain normal thyroid hormone levels. And the levothyroxine sodium, which is a synthetic form of thyroxine, was introduced for clinical use in 1949, almost 70 years back, which has revolutionized endocrine therapy over a period of time. However, though the therapy may look simple, just giving a tablet to the patient asking to take, maintaining clinical and biochemical euthyroidism in our patients with this particular drug can many times be challenging. So we will be just looking at illustrative cases, which will spread across the lifespan, as I was telling. To start with, we will have Dr. PG Sundaraman sir to give his opinion. The first case is that of a 40-year-old female who presents with history of weight gain, undue fatigue, cold intolerance, and increased menstrual flow, which are all very typical symptoms of untreated hypothyroidism, which she complains for a period of around 6 months, and for which she was advised to take a combination pill containing estrogen and progesterone by the gynecologist, and she's been taking this for the past 3 months. So on examination, she has all the features of gross hypothyroidism, including puffiness, and she also has a diffuse goiter. Investigation showed a total T4 level of 4.5 microgram per deciliter, which is lower than the reference range. And TSH is quite high, 68 milliunits per liter. And the anti-thyroid peroxidase antibodies were quite high, suggestive of an underlying autoimmune thyroid disease. So with that background, I would invite Sir to give his opinion on what happens if the hypothyroid state remains untreated, or in short, what are the consequences of untreated hypothyroidism? And following this, how do we initiate treatment in these patients? What is the dose of the drug we initiate, and how frequently we test, and how long do we continue therapy? Dr. Sundaraman sir, please.
Okay, thank you, Dr. Velayudham, for the nice introduction. And he has projected a case which is a simple, straightforward primary hypothyroidism with low total T4 and elevated TSH. Now, thyroid is a quite important unique gland that controls the mind, body, and soul. So it affects from the head to the toe. And the clinical spectrum is maybe a florid symptoms, or it can be a very subtle symptoms. The signs also can be florid, or it can be subtle. So he has not projected the clinical picture, but anyway, he has given the symptom signs like weight gain, undue fatigue, cold intolerance, and increased menstrual flow. So from this, as I told you, it can affect from the womb to the tomb. This is a case which is occurring during the reproductive period of a lady. And this definitely causes a menstrual arrhythmicity. It can also result in infertility. And in cases where the patient becomes pregnant, it can cause abortions or complications during pregnancies. So these are related to this particular case scenario, and these symptoms and signs can vary depending upon the age group that the thyroid dysfunction occurs. Now, what and when to start this patient? Why, if it is not started, what will happen? Now, many patients, it depends upon the clinical symptoms and signs and the scenario. Many times it becomes undiagnosed. They carry on for a long time without treatment. They don't have any problem, but this problem persists, like the menstrual irregularity. It can cause the undue weight gain. It can cause fatigue. It can cause cold intolerance. And finally, it affects the various organ systems like heart, kidneys, nerve systems. And then this patient may go into a florid myxedema and can lead on to myxedema coma. So the symptoms are florid. So it is very ideal whenever you find this particular clinical history, we must check for thyroid disorder. And if you find a value of low T4 with elevated TSH, is the ideal candidate to start on thyroxine therapy. Now, what is the thyroxine that is used? Usually we use levothyroxine, and the dose is roughly about 1.6 to 1.8 micrograms per kg body weight per day to start with. And depending upon your clinical picture and the laboratory value, we try to monitor these patients. Now, what are the ideal levels of the T4 and TSH? Normally, in India, we only do a TSH level, and we allow them to keep to less than 3 so that it is ideal for them. Sometimes we also keep it a lower level, where less than 2.5 when the patient becomes pregnant. And after starting the medicine, you're going to monitor these patients by doing a TSH. Initially, we also combine with a T4 level, and it is done after a period of 6 weeks. And after ascertaining, then we can step up or step down the dose depending upon the laboratory value and the clinical picture. So don't rely only on the laboratory value, but also on the clinical picture. And then you can do it, still it is stabilized every 6 weeks, then every 3 months, 6 months, and finally annually. And even there are studies where it can be done once in 18 months, depending upon the clinical picture that you come across.
Okay. Thank you, sir. So there was a simple explanation of how do you treat a patient with florid primary hypothyroidism. But again, people come across with this specific queries. When should I take the tablet? Whether should I take in the morning or in the evening? Should it be taken with meals, before meals? And even clinicians have this concern. So any comments on that?
There is a surge in the early morning, and there is a nadir in the late evening. And normally, this thyroid medication, such as the levothyroxine, is taken in the morning ideally between 8 to 10. And as also the previous speaker has highlighted, that whether with food or not, it doesn't matter, but the time matters to a great extent. Now, regarding the food intake, they have shown that caffeine interferes with the absorption of thyroxine, because basically down south, a lot of people take coffee, and normally we must refrain any food items for 30 minutes after taking the medicine or before taking the medicine, but the food must be nearly 2 to 3 hours. If you're taking any medication, the gap must be more than 4 hours. So these are some of the prerequisites. But there is one problem, especially in the pediatric age group. There are instances where the child goes to the school at an early morning schedule, so they cannot stick to a particular time schedule, and the child gets up very late. In those situations, it can be given 3 hours after dinner. So these are some situations where, and in elderly population where you don't have a compliance, you don't have the guidance of anybody, then there are instances where it is given once a week, which is 7 to 10 times the daily dose can be given. So these are certain situations where we give the medication accordingly. And normally speaking, it must be given the morning between 8 to 10, ideally before breakfast or with the minimal breakfast, and the gap of food or coffee must be half an hour. Between any medicine, it must be 3 to 4 hours.
Thank you, sir. So with that, we'll move on to the second case. Again, this is a child who undergoes routine newborn screening at birth. And surprisingly, the TSH was found to be very high with values of more than 100 and with corresponding T4, which is quite low. So again, this is a very clear-cut case of primary hypothyroidism, which is picked up at birth. So usually the diagnosis gets delayed due to several reasons, but with increasing newborn surveillance screening at many centers across the country, we tend to pick up congenital hypothyroidism much earlier. So this child has congenital hypothyroidism. So we would like to know from you, how do we go about this patient? Do we start treatment immediately, or we wait for some other workup? Is the dose same as that in adults, or it's quite different? Are there any concerns of using thyroxine in children, or is it quite safe therapy? And how long do we treat again? So is there any possibility that this child may be stopped off thyroxine, or should the child take it lifelong? Can you briefly tell us, sir, please?
Yeah. Physiologically, there is going to be a surge of TSH after the birth, around 24 to 48 hours. Followed by the TSH, there is an elevation of T4. So that must be kept in mind. But if you have a clinical picture of, and one also must, most of the cases are missed. They don't have the florid signs of hypothyroidism. Well, around 5 to 10% can have a florid signs. So you may miss. That's the reason why we have a neonatal screening program, so that we'll identify and treat these cases. And the cutoff value is usually around 20 and more than 20, and where the low T4 is there, then definitely this warrants treatment. It depends upon what initially by cord blood or the filter paper method, then you can do a venous sampling to authenticate it. And when the values are between 10 to 20, we can reassess after 2 weeks. If there is no decrease in the T4 levels and there is no florid signs. If there is a decrease in T4 levels and between 10 to 20, that also warrants to start the treatment. Less than 10, it is doubtful. A recent paper last year where they've shown that you don't decrease the cutoff value less than 15, because that also may predispose to over-treatment of the neonates. And here, the thyroid medicine that we normally use is levothyroxine. We don't use T3 or thyroid extract. And the dose is higher in neonates and children compared to the adults. So the starting dose of the levothyroxine is around 10 to 15 micrograms at the newborn period, and slowly decreases to 8, 6, and 4, and 3, depending upon the age, micrograms per kg body weight. Now, they've shown that thyroid replacement at the earliest stage, less than 2 weeks, and a dosage of 9.2 minimum micrograms per kg body weight is very ideal to prevent the neurological dysfunction or cognitive disturbances, speech, and other metabolic disturbances. Earlier treatment before 2 weeks is very essential. That's the reason why neonatal screening is a must in our country. And the T4 and the TSH must be brought under control before 3 to 4 weeks. Now, what are the values that we are going to aim in children is that to keep the T4 level at the upper normal levels and the TSH less than 2. So this is going to be the ideal levels to start with in all neonates in the pediatric age population. Now, once you start the thyroxine therapy, you can monitor these patients after 6 weeks, and every 2 months till you are normalizing the T4 and TSH. One more important situation that especially in the pediatric age group, the T4 becomes normal, but the TSH is elevated. So in this type of scenario where there's going to be a delay in the maturation of the hypothalamo-pituitary thyroid axis must be kept in mind. So there's no need to chase the TSH very rarely. And another important scenario where you have is a transient hypothyroidism that also can occur, that must also be kept in mind. So these are situations which depends upon a particular individual. So individualize the treatment, but basically we must give a very stiff dose of thyroxine. It is not like adults where you're going to step up the dosage. So you give the full dose at the start, and after the T4 and TSH are in a position that it is ideal, then you can monitor it every 3 months for 1 year, then 6 months, and every 6 months thereafter, and based upon the requirement every 1 year. So these are the various ways of monitoring these children.
Okay. So I think, see, sir wants to say that the screening should be aggressive, the treatment should be aggressive. If you are in doubt, start treating the child and then reassess later. Usually the treatment is lifelong, but there are such certain situations where the congenital hypothyroidism can be of temporary nature, where you can reassess always.
Yeah, you can have, you must reassess unless until there are indications where you find that there is going to be agenesis or atheriosis, or it is going to be an ectopic thyroid. There is no need to reassess. So what they do is do a nuclear scan or an ultrasound to find out whether there's a thyroid gland or not. If there is no thyroid gland, there is no need to reassess these patients. You must continue lifelong therapy. If there is an adequacy of the thyroid gland is present, then we can reassess patients after a period of 3 years, where we can stop it for a period of month and reassess them. We allow this 3 years because we presume that the neonatal neurological development becomes really normal by the age of 3 years.
Okay. So this itself is a topic of discussion, but since we are running short of time, I think we will move on to the next case. This is for Dr. Anjali Satya. This is a young female who is married for the past 2 years, but she is anxious to have a child, is planning pregnancy. Apart from this, there is no past medical history, but there is a family history of autoimmune thyroid disease running in the mother and sisters, and she had never screened herself for thyroid function test before. And when she comes for a consultation during routine investigation for subfertility, the thyroid function is being done, which shows T4, which is within the reference normal range, and TSH is 7.5, which is again above normal range, with positive anti-T2 antibodies. So the discussion points here would be, do you really think that this lady would benefit from thyroxine therapy? And if yes, what are the benefits in terms of subfertility and pregnancy? Then treatment targets, is it same as overt hypothyroidism or something different? And consider a scenario where the TSH is within the reference normal range, but antibody is positive. Would you still consider treating her with thyroxine in this case? So can we have some comments from you, Dr. Anjali?
Good evening. Thank you, Dr. Velayudham. I think coming to this case, this is a young woman, 24-year-old. And what is obvious is that she's married for 2 years and she has not, conceived. So the first problem here is subfertility, which is defined as inability to get pregnant in spite of trying for 1 year. So second identified problem here is that she has subclinical hypothyroidism due to the fact that TSH is between 4 to 10 and total T4 values are normal. But what we see here is a positive family history of autoimmunity, and she herself has a positive thyroid antibody titer. So as Dr. Sundaraman had said in the last slide, that thyroid hormone receptors are ubiquitous. So manifestations are seen in all systems, including reproductive system. So it is not only restricted to the woman, but to the male as well. So how does hypothyroidism cause subfertility in a woman. One is presence of menstrual disturbance itself. Almost like 30% of women, more so those with overt hypothyroidism, they present with irregular cycles, which is highly suggestive of anovulation. That is, they do not ovulate. So they have irregular periods. And second probability is, as we all know, primary hypothyroidism, especially overt hypothyroidism, can cause secondary hyperprolactinemia. So when there is a high prolactin level, there can be a luteal phase defect, and that may suppress ovulation. And third problem that we face is autoimmune thyroid disease can be just a marker of overall autoimmune dysfunction in an individual. So as we all know that in a polyglandular autoimmune syndrome, autoimmune thyroid disease may be just one manifestation. It may be associated with autoimmune dysfunction of the ovaries as well. So some of these women may have premature ovarian insufficiency, and which has to be evaluated, especially by looking at their FSH and AMH values. So they may not have the tendency, or they may not have reserve eggs in them. So that is a third mechanism where a woman may not conceive with a history of autoimmune thyroid disease. And fourth is, of course, a woman who has polycystic ovarian syndrome, which is a very common problem in the current scenario because of high prevalence of obesity. We see almost like 25 to 30% of young women presenting with polycystic ovarian syndrome, and 25% of these women may have autoimmune thyroid disease as a presenting manifestation. So now we know that if they have thyroid dysfunction, if we try to correct it with thyroxine, probably they may start ovulating, they may conceive without any further intervention. Second is the secondary hyperprolactinemia, if present, may also get corrected. And third thing, also it may aid in weight loss and also help in ovulation. Now, this is a scenario which is concentrating on the woman, but I would also like to mention that hypothyroidism can affect fertility in men also. So in men who present with primary hypothyroidism, it can affect the semen parameters, especially it can even reduce the volume, the sperm counts, progressive motility, and most importantly, erectile dysfunction. So nowadays they say that if a man comes with erectile dysfunction, he should be evaluated for both hypothyroidism as well as hyperprolactinemia. So I think in this scenario, here we have identified that she has autoimmune thyroid disease. We need to treat her for these reasons. Now, the second reason we would want is that if she gets pregnant, what is the likelihood that this subclinical hypothyroidism becomes overt? This is highly likely because she has a very strong antibody titer. So those women who have high thyroid antibody titers, if they have borderline hypothyroidism, it's highly likely that once they get pregnant, this subclinical hypothyroid state may turn to an overt hypothyroid state. And that we know is associated with adverse pregnancy outcomes. Like we know that overt hypothyroidism and also subclinical hypothyroidism to a lesser extent is associated with spontaneous pregnancy loss, recurrent miscarriages, preterm delivery, gestational hypertension, placental abruption, and so many other maternal complications. Also, it also leads to other neonatal outcomes, also adverse neonatal outcomes like impaired neuropsychological development, a higher prevalence of NICU stay, a low birth weight. All these are problems which are anticipated if a woman has hypothyroidism in pregnancy. So I think when we identify this problem pre-conception and in a woman who is struggling to get pregnant, it would be, evidence is very strong now to treat them with thyroxine. And what would be the ideal preconception value? We would like to keep the TSH below 2.5. And these women who have thyroid antibodies must be followed up. So once they conceive, we must follow up their thyroid function as soon as they get pregnant, because we expect the thyroid hormone replacement requirement to go up by almost like 30%. Because pregnancy is a high demand state. And the fetal thyroid function starts functioning only after about 13 to 14 weeks. So the initial few weeks of pregnancy, the fetus is also dependent on the maternal thyroid hormone reserve for the fetal brain development. So this 30% dose increment is expected, and hence we need to follow this up very closely as the woman gets pregnant.
Okay, so the last question which I advise, any benefits of giving levothyroxine therapy to antibody positive patients, but still the TFT within?
Yes. Now, we do not have a very robust data, but yes, women who are euthyroid and who are thyroid antibody positive, who had already experienced a pregnancy loss, probably it would be worthwhile to put them on thyroxine, because if you look at the benefit versus risk ratio, there is no risk of treating them with very smaller doses of thyroxine, like to the tune of 25 to 50 microgram. Or if women are euthyroid antibody positive who are trying for a spontaneous pregnancy, I think it would be ideal to wait and watch and follow them up as soon as they conceive. So if they develop subclinical or overt hypothyroidism in pregnancy, I think that would be the time to treat those women. So with a history of a bad obstetric history or a recurrent miscarriage in the past, or if they are going for IVF conception, in that case, if the TSH is more than 2.5, it is, there is evidence to suggest that yes, for those women who are going for ART, euthyroid antibody positive, we can bring down the TSH to below 2.5 before they go for an assisted reproductive technology.
Yeah, thank you. See, the message Dr. Anjali wants to say is that your threshold for starting thyroxine can be very low, particularly in reproductive age when the female is trying to conceive or there is bad obstetric history. But the only thing is that you have to closely monitor them. You just don't start them on thyroxine and forget. People take thyroxine without monitoring for years together for no reason. So if you decide to start thyroxine for reasons like this, then advise the patient to have a proper follow-up and keep them under monitoring so that the thyroid function is kept under check. So the next case for Dr. Anjali is that let's assume that we started this lady on thyroxine and the thyroid function normalized over a period of time, and she becomes pregnant in 6 months' time. Then again presents to you at 6 weeks of gestation. So do you really continue thyroxine in pregnancy, or do you adjust the dose, or just continue the same till delivery? And do you wish to continue thyroxine after the delivery, or you wish to stop and reassess? What about how do you take this case further?
Now, answer to question number 1, yes, we do continue thyroxine in pregnancy. I think this message should go to all women even before they start their pregnancy. In the prenatal visit, if they come for counseling, we should tell them that we are putting you on thyroxine, and once you get pregnant, please do not stop medicines. Because many a time women, they tend to stop all medications once they get pregnant. Second thing, as I mentioned earlier, if they already have thyroid antibodies positive and she was having subclinical hypothyroidism, we need to follow up the thyroid function as soon as they get pregnant. And in pregnancy, we may have to monitor the thyroid function very closely. Now, as Sir had mentioned in the initial slide, that once we start up individual on thyroxine, the first test, repeat test, is normally done after 6 weeks because the half-life of thyroxine is 7 days. So it takes 6 half-lives for steady state to be achieved. But pregnancy may be one exception where we try to reassess much early, maybe within 1 month itself. In early weeks of pregnancy, we may have to monitor every first 4 weeks later, and thereafter every 6 to 8 weeks till mid-pregnancy. And thereafter, usually the dosage requirement stabilizes. So dose adjustments are, yes, we try to keep the TSH below 2.5. And as the woman gains weight during pregnancy, her dose requirement may change considerably. Normally, what we see is that compared to the pre-pregnancy dosage, there is a 30% increment in dose requirement. Now, suppose a woman comes from an area where she doesn't have immediate access to, say, a blood testing before they come for the first antenatal visit. Probably we can tell them in their prenatal visit itself that as soon as they get pregnant, they can take 2 extra tablets per week, which will almost like amount to 30% increment. And the ideal TSH in pregnancy would be to keep it below 2.5. Then how frequently, as I have already mentioned, every 6 to 8 weeks you can monitor in pregnancy. After delivery, now if a woman has already had overt hypothyroidism before pregnancy, then we have to come back to the preconception dosage after delivery. So if she was, say, already on 50, her dose requirement had changed to 75 during pregnancy, then after delivery, we can ask her to go back to 50 microgram and thereafter assess 6 weeks postpartum and thereafter every 6 monthly. Now, women who have subclinical hypothyroid, whom we have put them for probable benefits that they can achieve, we can actually stop the medication after conception and reassess them. Now, women who are thyroid antibody positive, they are also likely to develop what is known as postpartum thyroiditis. There is a very high risk that these women who have strong thyroid antibodies may have borderline thyroid functions, but they need to be followed up. So this should be told in pregnancy that after delivery, they must not disappear. They must come back for a review. And Usually this postpartum thyroiditis has 3 phases. So initial weeks postpartum, they may be thyrotoxic. So they may actually lose weight, which they may attribute to probably hours of lack of sleep and childcare. And if we tell them that this phase is expected, initial few weeks up to third month, they may be actually thyrotoxic, and then it settles down. And by 6 months postpartum, they become overtly hypothyroid. So we should be aware of this fact that women who are antibody positive are at high risk for postpartum thyroiditis, and they're also at high risk for postpartum depression. So these are things which we should watch out for in the postnatal period. I think the second question that you have asked here is a woman who presents in pregnancy with a very severe hypothyroidism. Now, this is not an ideal scenario. I mean, definitely not an ideal scenario where we wouldn't want anyone to identify severe hypothyroidism.
Yeah, this may be slightly out of context from the thyroxine therapy, but
I think
we get many referrals like this.
Yes,
Yeah.
so there is a very important message to it that we not terminate these pregnancies. All we need to do is we need to rapidly correct the hypothyroid state. And here, the dose, what we normally institute thyroxine is at a dosage of 1.6 to 1.8 microgram per kg body weight. But here we can start with little supraphysiological dose itself in young women who tolerate high dose of thyroxine very well. We can start them with as high as even 2 or 2.2 microgram per kg body weight. Rapidly normalize, reassess them in 4 weeks' time, and thereafter follow them up. So I think we have to just reassure the person that yes, we can rapidly correct this, and they must follow up regularly. At the set time, they should come back with the repeat follow-up visits and the dosage adjusting. And after delivery also, they must continue, because a woman who has a TSH of 100 most likely had overt hypothyroidism prior to pregnancy as well. So we must explain to them, and probably we should tell her all the warning signs, because we expect this woman to have adverse pregnancy outcomes. So if she has any spotting, or the obstetrician would take care of that. But I think abortion or termination of pregnancy would not be advised in this scenario.
Yeah, thanks. So that was the message which I think which should be passed on. Any comments from the other panelists as well, Dr. P.G. Sundaraman, sir, Dr. Vignesh, regarding the use of thyroxine in subfertility and pregnancy?
No, I think Anjali has highlighted very well that even in cases where it is going to be a normal thyroid function with elevated T4 antibody, the treatment warrants when there is a repeated pregnancy losses earlier. So that's a very important message that must be carried. And the second message is very important, that all the women who are planning for infertility treatment must be done a thyroid function test. So that is also a must in these things. And the third thing that Anjali has highlighted, that many people stop thyroxine soon after becoming pregnant. So that misconception must be taken out of them. So we must tell them thyroid is not an adverse hormone. So many times what the relatives say that they stop all hormones. The thyroid also is an equivalent hormone, so they stop them. So that's an important message that must be carried to the patient.
Okay. Vignesh?
I concur with the Anjali madam, whatever she said. And one thing I would like to add, see, if the patient had a overt hypothyroidism and we have continued thyroxine replacement, and we have increased the dose of thyroxine, and at the end of end of part time, I would tell the patient, as soon as they get delivered, on immediate day, next day after delivery, they can reduce to pre-pregnancy level even without checking thyroid hormone levels. So I will write a prescription to at the end to reduce it, so that the gynecologists won't, many times they won't be confused to how to go about with titration. And you need not check the thyroid hormone levels for next 6 weeks, because the post-pregnancy changes of T3, T4, Tsh will be present for almost 6 weeks after delivery. So to bring down the thyroxine to pre-pregnancy level and check repeated thyroxine testing after 6 weeks. And one more thing I like to add is, so all of these pregnant women will be started on iron and calcium replacement at 4th month of pregnancy after the first trimester. So I will tell them specifically, ask them to take the calcium and iron replacement, whatever they've been given by our obstetrician colleagues, to take it in the afternoon or night. At least the 4 hours interval should be there. Gap should be there between the thyroxine and this iron and calcium, because it may inhibit the absorption of the thyroxine. So that's what I like to add.
Sure, thank you. See, I could see that Dr. Feroz from the UK is also online. So can we have his opinion on these cases, please? Dr. Feroz?
Yes, thank you. I hope you can hear me.
Yeah, very well. Thank you, sir.
Wonderful discussion, and thank you everybody for the contributions. My clinical practice is slightly different in one respect to what has already been said, and that is in relation to patients who have positive TPO antibodies but are euthyroid, and whether levothyroxine therapy is indicated in relation to pregnancy. And the practice of giving patients thyroxine in that sort of context goes back to some studies that were done by a very good friend of mine, Roberto Negro, in Italy some years ago, showing some advantages and benefits. But that data have been reviewed and some new have been added. And Roberto himself no longer does that because the evidence is veering very much in favor of no benefit of thyroxine therapy in that kind of scenario. That's just my only comment. Slight difference in approach, I guess, to my practice.
Sure, sir. Thank you. Thank you so much for adding to the discussion. So I think we'll move on to the next clinical case scenario. This will be for Dr. Vignesh. Here we have a 67 years old female who was diagnosed with papillary thyroid carcinoma. It was stage 3 at diagnosis, and she was treated with thyroidectomy followed by remnant ablation with radiiodine, and she's on thyroxine suppression. This all happened 15 years ago, and she had been under follow-up. And she's on quite stiff dose of thyroxine to suppress TSH. The total daily dose she's taking is around 175 microgram per day. And the routine surveillance annually, which is being done for the thyroid cancer recurrence, doesn't show any evidence of recurrence, both biochemically as well as radiologically. And on routine questioning, she complains of mild dyspnea on exertion. So further evaluation is done, which shows LV dysfunction. There is slight reduction in the ejection fraction. There is no obvious evidence of any coronary artery disease for that matter. And she also has osteoporosis on routine DEXA scan. So the TSH is, the thyroid function is done again, which shows TSH of 0.01, which is the normal, which is suppressed TSH. And the free T4 is in the high normal range. So how do we go about this patient? Do we continue the same dose to suppress TSH, or do we modify the dose? And what would be the risk benefit in this patient of with the history of papillary thyroid carcinoma, which is diagnosed 15 years back with no recurrence now? Do we really need to adjust the dose or continue the same dose? If at all we decide to continue a higher dose like this, what would be the risks and benefits? So to discuss this, I invite Dr. Vignesh to give his comments. Vignesh?
See, this probably this question scenario is about what are the risk benefits in a patient with thyroxine supplementation or suppressive dose of thyroxine. So for general audience, I would say thyroid malignancy, we have treatment in 3 stages. First is initial surgery, total thyroidectomy, followed by a radiation ablation. And third, we'll continue with the suppressive dose of thyroxine, because TSH is a trophic factor for the thyroid malignant cells. So we suppress the TSH to 0 so that we can prevent the growth of malignant cells. So by giving a supraphysiological dose of thyroxine, we can suppress the TSH. So this is one form of therapy. So, and this TSH suppression, we have targets depends on the risk of recurrence. So if we categorize usually low risk, intermediate risk, and high risk. So, but unlike other malignancy, the thyroid malignancy, we use a dynamic staging. If the patient does not have any recurrence in the follow-up, that is after 3 years or after 5 years, we just lighten the target TSH. usually we keep a TSH less than 0.1 in 0.01 patients initially. If in 3 years period, if they don't have a recurrence, we usually reduce the dose of thyroxine so that we keep the TSH target between 0.1 to 0.5. Even after 5 years, if they don't have a recurrence, and thyroglobulin, which we usually follow them with the thyroglobulin levels. If there is no elevated thyroglobulin, we usually keep a lighter target, especially in elderly women who are prone to get side effects or adverse effects of supraphysiological dose. So we in last 4 case scenarios, we saw the benefits of thyroxine. This is about the risk of thyroxine, the excessive thyroxine supplementation. So one thing is that it can produce a tachycardia and an atrial fibrillation even with the subclinical thyrotoxicosis level. So when the TSH is suppressed below 0.1, there is a risk of atrial fibrillation, which has to be balanced against the risk of recurrence of cancer. So second thing, and supraphysiological supplementation, supraphysiological replacement leads to osteoporosis. It increases the bone turnover. It increases the resorption of bones, more often the trabecular bones. So it can lead to osteoporosis and osteoporotic fracture. So given a long history of follow-up, like 15 years of thyroid surgery and no recurrence, so I think the TSH target should be less than maybe around less than 1.5 or less than 2. So I think this patient should be benefited with lowering the dose of thyroxine. That is so that we can avoid a cardiac-related event like atrial fibrillation, or I think we can treat the osteoporosis initially by calcium supplementation, if at all bisphosphonate in this patient. So generally, elderly, we need to be very cautious. Not only this patient, if you want to start a thyroxine replacement in an elderly patient, we always start with the lowest. Though 1.6 microgram per kilogram is a standard dose for overt hypothyroidism, and elderly will always go slow. They may have an underlying cardiac dysfunction, which may not be manifested at the time. So those patients, elderly, or those who have a poor cardiac reserve or a known cardiac patient, will always start with the lowest possible dose, 25-50 microgram, and gradually titrate because they are prone to get a cardiac-related side effects. So this patient, I think, considering the lower risk of recurrence, and the benefit will be more by reducing the dose of thyroxine. So I think I prefer to reduce the dose of thyroxine and forward.
So I think Dr. Firoz is, yeah, sure.
Yeah, I did comment. Thank you very much. I totally agree with Dr. Vignesh, but I would like to add that in addition to the negative outcomes of osteoporosis and atrial fibrillation, there is now evidence that keeping the TSH suppressed in somebody treated with levothyroxine actually increases the risk of mortality. And there are 2 studies independently, one from the UK and one from Denmark, showing this very clear. And indeed, the study from Denmark showed that for every 6 months that a patient has a suppressed TSH, the risk of mortality goes up by 18%. So we now have really robust data on, in addition to outcomes such as cardiovascular risk and osteoporosis, also on mortality, which I think tips the balance very much in favor of reducing the dose of thyroxine, as you said, in this case.
So yeah, as an extension, what would be the ideal TSH target in these cases with treated thyroid malignancies? Dr. Feroz?
You're asking me, okay, right. I think most endocrinologists and cancer specialists would aim for a TSH somewhere within the middle of the normal range. That is the totally empirical approach, and seems to be a reasonable balance between the risks of recurrence and maintaining sort of normal thyroid status. But I don't think there are any robust data that show you whether you're at the lower end of the normal range or the upper end of the normal range that materially changes the risk. I think common practice is to try and aim somewhere in the middle.
Sure. So I think you'll be talking more on subclinical thyroid disease in your talk, I hope. And with that, I think we'll move on to the final case scenario. So here we have, this is a common clinical situation which every practicing physician encounters at least once in a lifetime. So he is a young male who is working in a IT field for that matter. And he was diagnosed to have primary hypothyroidism 5 years back. He had been having a stable thyroid function till 2 years back. And for the past couple of years, he does work out at the gym under a trainer. And he has frequent change of workplace. He shifts his workplace from one city to another. And however, he comes back to you for the routine thyroid function once in 3 to 6 months. But when you do the thyroid function, you see that the thyroid function test keeps fluctuating despite you keep adjusting the thyroid dose, thyroxine dose. And the recent thyroid function test is like this, where you can see that the free T4 is the lower level of the reference range, 0.9 nanogram per DL, and TSH is really high, 30 milliunits per liter. So the points which we would like to discuss here is that, sorry. So why, how can you explain this situation? The possible reasons for persistent elevation of TSH despite the patient being on thyroxine therapy. The question is to Dr. Vignesh again.
Okay.
Vignesh?
Okay, so the patient already on stable thyroid function on with replacement. So suddenly change in pace of work and started working out in gym. So some variation in thyroid function test. I would say I would find at least 2 or 3 reasons why he could have a variation in thyroid function test. Because change in workplace, maybe change in shift duty, he may have skipped some few doses of thyroxine in between. That could be the most common. As it is complaints issue, maybe a most common we encounter in our clinical practice. One. Second thing, most often in gyms they use many times they use a cocktail of growth hormone, testosterone, all those things, hormone supplementation. I mean, over the counter they start by gym trainers. So that may change the total hormone values. Like what we see in pregnancy, T4 will rise, all those things. The demand will increase. So they may require a higher dose of thyroxine for control to suppress the TSH. Second thing. Third thing, they may be on supplements like soya for protein supplements, which may inhibit the enterohepatic circulation of the thyroxine. So they may have poor absorption of thyroxine. So they may need to, in which case, or he may be on other iron or calcium supplements, which may inhibit the absorption of thyroxine, like soya. So in which case we need to increase the dose of thyroxine. So,
yes.
One thing, so I need to probe a detailed history, how about the compliance, whether he is skipping the dose. So suppose he is skipping the dose, I would tell them to go ahead with a steady dose, regular dose. Generally, the longer T4 has a long half-life of 7 days. Skipping a single dose may not affect the generally steady state, but though the textbook says a person skipping a dose can take two tablets of thyroxine on the next day, it will not alter the equilibrium. Generally, we don't follow them in practice because the patient used to do that very commonly. So if some very exceptional cases, we can tell them to take the 2 doses of thyroxine if they forget to take a dose on the previous day. That is one thing. And ask him about history of any hormone, hormone supplementation or injections of testosterone or growth hormone, which may be the cause. Third thing about the protein supplementation, soya supplementation.
Yeah. So this patient actually was taking soya supplements regularly after he started working out, and once he was advised to stop that, then there was some improvement in thyroid function. So any other comments from the other panelists? Ranjali, any comments on high TSH despite somebody being on thyroxine therapy? We're not able to hear you. You're unmuted.
You're muted.
I think in this given scenario, we can't think of too many differentials, but otherwise, I mean, here I would think one is check the compliance. Rule number 1, check compliance. Second is the patient taking any supplements, whey protein, soya protein, and things like that. third thing, I mean, in an say not in this scenario, but probably we should also rule out history of any chronic gastritis, especially people who are on PPIs, a change of workplace, and sometimes patients may be taking concurrent medication. So proton pump inhibitors, or if they have had a chronic gastritis, or if they are and all that can also sometimes impair the thyroxine absorption. And if they have any malabsorption state, here obviously it is not the case, but any GI disorder like celiac screw, or even patients who have undergone bariatric surgery, and malabsorption state is again one more important differential in other scenarios.
Okay. See, and any comment on the bioavailability of various thyroid hormone preparations that could affect the thyroid function test? So we commonly see that people get generic brands, and then once we switch to another brand, then the thyroid function improves. So any comment on that?
I'm just worried because this patient was stable for 2 years with the thyroid function. He's having hypothyroidism for past 5 years. After 2 years, I think till 2 years, why he was stable. So I think we must ask whether he has gone to any other form of thyroid extract treatment or native medicine treatment. Many times I've seen patients of thyroid problem, they switch on to homeopathy type of medicines, especially coming from other states. I've seen a lot of patients switching on to the homeopathy part of treatment. So they reduce the levothyroxine and they switch on to homeopathy. So I think that must be kept in mind. And the second important thing is that there is a wide use of proton pump inhibitors. That must be, and unless until we go and ask them, because here you have shown clearly that he was stable for 2 years, suddenly something is going wrong. So there must be some compliance or medication, or it is a food habits. And these are definitely going to play an important role for this fluctuation, I think so.
Yeah. So actually, that's what the compliance was an issue with this patient, because he kept changing places. So he forgot his prescriptions. And the other thing was the soya-based drinks he was taking as a part of protein supplements. So once they were switched, then his thyroid function started improving. So we have around 5 to 10 minutes more.
So I have a question with Dr. Petros, because we have a problem. The earlier case that you were telling that the initial studies by Negro et al., which showed evidence of treatment of autoimmune thyroid with normal thyroid function had a benefit. But here, definitely the latest studies have shown not much benefit. But we have a very important picture where the patient goes to repeated pregnancy loss, and who are on IVF and XC treatment. So in these type of cases, whether we require to add this medicine, by adding a medicine of thyroxine, a small dose, does it have any bad effects on the mother, or it will be added benefit for them? I don't know, because many times we are faced with the obstetrician telling that the patient has gone to repeated pregnancy loss, and there is a very high degree of autoimmunity. And here in the scenery of iron deficiency in this part of this world, do you have any suggestions to tell to us? Because this is a very big problem, because we must deal with the patient, the obstetrician, the economic cost of undergoing IVF, because IVF is not covered by the insurance. They are covered by the patient. Can you give some suggestions, please, sir?
Yes, thank you. No, I hear what you say, and I think it's very, very well talking about this in the context of a meeting when you're faced with a patient who is anxious, who's had bad experiences, and has expectations of you to do something about it. That's a different scenario, and of course you need to handle it. So the question is, I think, are there any risks in putting some of these patients on a small dose of thyroxine? Well, probably not. You're not going to do any harm. With any treatment, it is possible that you may end up over-treating them. So one needs to be cautious not to do that, because that in itself is detrimental. And I think it depends very much on the patient. Some patients will be very burdened by having to do one more thing to remember to take the thyroxine and then to feel guilty if they don't. So there is an element of the individual patient's psychology on how you approach it. And I think I would agree with you if the patient is extremely keen, is very worked up, really wants to have it, there isn't a very good argument to deny it, as long as you keep a close eye. But I think giving everybody in that situation thyroxine is not entirely the right approach, because there will be some that will be burdened by that unnecessarily.
Thank you, sir.
Thank you.
Have we got time to make a comment about this?
Yeah, we have 5 more minutes.
Yeah. So, I mean, interesting, we see a lot of this over here in the UK, and, overwhelmingly the likelihood here is lack of compliance or non-adherence. We're not allowed to say lack of compliance anymore. One of the driver for that, I think, is that patients may expect to have an immediate response from being on thyroxine or restarting thyroxine when they've interrupted their treatment. And I think that's something that maybe we have a role in educating patients. So if this person goes back on full doses of thyroxine, he will not feel any different for several weeks. And there's that tendency to reject the treatment because it isn't working. I mean, all of us are wired up into thinking that if we're starting treatment, we should see the results immediately. So making them aware that the benefits of the treatment are not going to be immediate. They're going to take weeks. It takes, for most symptoms of hypothyroidism, at least 3 months to be reversed. And we think that some of the cognitive and neuromuscular symptoms may take much longer than that to be completely reversed. And I think that's one of the possible reasons. And if I may say just one other thing about formulations. So formulations do make a small difference. There was a recent study from the Netherlands that actually showed it wasn't such a small difference. It was a significant change in thyroid function tests, and that can drift. There is a formulation which may have a role in people who lead a very busy life, can't wait for 30 minutes, before having breakfast and so on, or may have some comorbidities that interfere with absorption. And that is, there's a liquid formulation which is made in Switzerland and a gel formulation. And there are some data that it is absorbed much better than other ordinary tablets. And that may have a role in specific cases. The downside is it costs about 100 times more than levothyroxine.
Okay. Thank you so much, sir. See, we have only a couple of minutes. We need to take some questions from the chat box as well. So we need some quick comments from the panelists. So how long do we need to stop thyroxine before you do a repeat thyroid function test? If at all you want to change the dose, how long do you wait? So I think the answer is very simple. Yeah.
You reduce the dose and repeat it after 6 weeks. And then see whether the thyroid function is normalized.
Yeah,
as it's rising up, you restart again. That's all.
Yeah, previously we are talking about the half-life of thyroxine, which is 7 days. So you wait for at least 3 to 4 half-lives. And what is the role of weekly thyroxine, which came a few years back? So does it still have a place in hypothyroidism management? What's your comment?
When the compliance is poor, then I think you don't have any people, very elderly population. We usually, I think I've started only 1 or 2 patients, maximum 5 patients, where I've given 500 micrograms per week, where they don't have any attenders around it. So somebody must be educating them, and in those type of very rare situations, once a week can be given.
Dr. Anjali, any comments on weekly thyroxine?
I have not tried that on patients. I think in elderly patients, I would have a worry that because whenever we give a weekly dose, we are actually giving a massive dose of 1,000 microgram. And this can actually elevate the FT4. I mean, they have theoretically looked at 1 hour, 2 hour, 3 hour values, and it happens to be a test of malabsorption. So FT4 actually climbs to supraphysiological levels within few hours of giving a very high dose of thyroxine. So can we precipitate arrhythmias in these patients is my concern. So I have not actually tried it in patients.
Okay, and this is a final interesting question based on the last case. So you consider that the TSH is still high despite on thyroxine. What is the maximum dose you try to give? You stop short at some point or just keep on increasing the dose?
We could keep on increasing the dose. We did not go by a weight-based dose. We keep on increasing, and I mean, after ruling out the compliance issues or other, other interfering drugs or agents, so we can increase the dose. I think some patients with the malabsorption, especially with the pernicious anemia or sprue, they require almost up to 300 microgram at a single dose. We have given in some patients. Maybe 1 in 500 patients, maybe like we come across in our clinical practice, we use 200, 250 microgram a single dose. We do. So we can increase and we can monitor every 6 weeks. Every 6 weeks till we normalize the TSH.
The answer is
keep
that
in mind that conceptive hypothyroidism is a very rare situations where hemangiomas liver can cause that is called conceptive hypothyroidism. But I think that we can do the test for the thyroid function where you see that what is the level of thyroid by giving dose of thyroxine. That is a test for it.
Yeah, absorption test we have.
Yeah.
So I think the time is up, I think, and thank you everyone for the wonderful discussion and the contributions. And I thank the delegates as well for the interesting questions they have asked. And my thanks to the organizers as well. And I'm just back to the organizers. Thank you, everyone.
Thank you.
Thank you.
Thank you. Thank you.